Everybody, or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by CoventBridge. And we had to reschedule this one, so thanks for your flexibility for those of you who registered for the first one, and happy you're joining us again. This one is called Connecting the Dots, VBC Revenue Integrity and FWA, which is Fraud, Waste, and Abuse in Integrated Compliance Model. So we have a couple items of note before we get started. All attendees have joined in listen-only mode, so this is a traditional webinar format, so you don't need to turn off your microphone or your camera or anything. We are going to have some time for some Q&A at the end, so if you have a question at any point during the presentation, go ahead and use your attendee module. There's a place specifically for questions, and drop that in there. And we're going to get to as many of those as we can. If we run out of time, or if we're not able to get to yours for some reason, don't worry. Someone will reach out to you via email afterwards to make sure your question gets answered. Finally, the session today is being recorded. So what's going to happen is when we conclude, maybe about an hour or so afterwards, you're going to receive an email, and that'll have a link to the recording as well as to where you can download today's slides. And you'll want to do so because there's a lot of great information there. So without further ado, I wanted to briefly introduce our speakers today. We have with us Mr. Ray Evans, who is the Vice President of Healthcare Sales, and he's going to get us kicked off in a minute. Then we have Miss Amanda Brown, and she's the Vice President of Revenue Integrity, and Colleen Gianastasio, and she's the VP of Compliance. So welcome all, and Ray, I'll turn it over to you at this time.
Awesome. Thank you, sir. Welcome, everybody. Appreciate you taking the time to spend with us here today. Obviously, that's a very long title, but we all know that as siloed as like health plans are, and healthcare organizations in general, trying to connect these dots and get an integrated program within the organization is paramount. To keep headlines like this from popping up and you being involved in them, which nobody does want to be in the headlines, right? This is just a small snippet of the increase in fraud, waste, and abuse that has happened over the last several years. And I think some of you know, with some large data breaches that have happened over the last year and a half, that has certainly ramped things up significantly, which one I'll point out, the first one on the list, the largest healthcare fraud bust on record. Yes, we were a part of that. Of course, DOJ and OIG take the credit for that, but us and the other organizations that found it and did all the work, our job is to try and keep all of you from being involved in any of these, and it's ramping up quick. On to the next one. And to that point, there's a big number, 1.9 billion. For those of you who don't know who we are, we run the UPIC, the Unified Program and Integrity Contractor for the 11 Midwestern states for CMS, which we've done for the past 25 plus years. This number is very significant, and it speaks to what I just mentioned a minute ago. So last November, we hit a milestone of, within the UPIC, we identified $1 billion worth of overpayments just within those 3 states, those 11 states. And that's traditional Medicare, Medicaid, fee for service. Okay, that doesn't even count all the other lines of business that a lot of health plans do. But the real significant ramp up here, I had mentioned about the data breaches. We knew that this would really fire things up, for lack of a better term. Well, from November until the end of March, that trailing 12-month number went from 1 billion to what you see there, 1.9 billion, almost a double in a 4-month period of time. So it is very timely. And the next slide that we see, I'm going to speak to a number that everybody looks at me like I have 4 heads when I bring this up. But it is true figures, and this comes from CMS, and 3 to 10%. 3 to 10% of every claim in the United States that gets submitted has some form of fraud, waste, or abuse in it. Yes, when you think about how big those numbers are, they are huge. Hundreds of billions of dollars every year go out the door that shouldn't and may not always be egregious or bad, but a lot of it is. And that speaks to the largest bust. So that's kind of brings us into this into our presentation. I'm going to pass it over to Miss Colleen.
Thanks, Ray.
Uh-huh.
So today we are going to pack a lot of information into our short time together. We're first going to discuss how our landscape is changing. Then we'll discuss the benefits of combining payment integrity and SIU efforts. When I'm done there, I'm going to hand it over to Amanda, and she's going to talk about some synergies to be gained by combining efforts. And then we'll end up with some key performance indicators that you can use to measure success. So for many years now, the industry has been shifting from fee-for-service to value-based care. And that road to value-based care has proven quite challenging. It's not quite as straightforward in value-based care as it is in fee-for-service. So fee-for-service is where providers get paid simply based on the services or tests and lab work that they send a patient for. Value-based care involves improving patient care and outcomes at the lowest cost possible. So this requires a big shift in focus from CPT and procedure codes, what you do for your patients and your members, to a focus on diagnosis coding that tells us how sick our patients or members are. So just remember, CPT tells us what you do to a patient, diagnosis coding tells us what's wrong with the patient. Value-based care increases and introduces a tremendous amount of complexity. And whenever there's complexity and confusion, it creates an environment for fraudsters to thrive. And that's what we're trying to avoid here. So we can go to the next slide. In today's discussion, we're going to challenge you to rethink the way that your organization works together to prevent and combat fraud. Historically, and even currently, most organizations have their payment integrity teams and their SIU units working separately. Our teams in payment integrity focus on ensuring that the claims payment is accurate by making sure that the correct party is paid, that the member is actually eligible for the benefits being rendered, and that all contractual requirements are met. Whether payment integrity is one team in your organization or several teams working together, they are a very powerful tool for cost containment. Now, our SIU units, on the other hand, are usually a smaller team of dedicated employees that look to identify and stop healthcare fraud schemes. The shift that I talked about before to value-based care makes their job a lot harder. Couple that with post-pandemic issues like the expansion of telehealth, the introduction of AI, financial pressures, and limited resources. And you can see how a small team can quickly become overwhelmed. If your organization is siloed and these two teams don't talk to each other, it could lead to myopic vision where you're only looking at what's in front of you and failing to see that bigger picture. And oftentimes this leads to duplication of work. Bringing your two teams together is going to allow you to operate more strategically. We can go to the next slide. So as we go into our discussion on connecting the dots to success, bringing these two teams together really is as simple as it helps with more comprehensive fraud detection, improved investigation success, reduced revenue loss, and increased transparency. We can go to the next slide. So here's some more benefits. First, there's early intervention. As much as possible, we're going to recommend that you bring your fraud, waste, and abuse efforts to prepay. And you do this by introducing new claims edits where you can stop the loss before it happens. Once that money is out the door, it's very hard to pull it back in. That early intervention and that prepay look helps in a number of ways. The first is provider education. Now, everything is not fraud. And like I said, value-based care is really complex and there's confusion. And a lot of our providers were brought up in that fee-for-service world. So mistakes are made. But when we bring our efforts to prepay and we combine team efforts, it allows us to identify those opportunities for either one-on-one provider education or broader network education. Avoiding costly recovery is another benefit. Once that money's out the door, it's very hard to get back. And in most cases, it's challenging or nearly impossible to get the full recovery back after it's gone out the door. And then lastly, we want to ensure regulatory compliance. Ray kicked us off with a great slide that shows all the headlines, and that's what we're trying to avoid. Nobody wants to be in those headlines, so we have to ensure regulatory compliance. Easier said than done. I'm going to share some of my experiences, and I'll give you a little bit more detail on how fraud, waste, and abuse occurs in value-based care. So upcoding, we've all heard of it. It exists both in fee-for-service, it exists in value-based care, but it looks very, very different. Upcoding in fee-for-service is simply stating that a procedure that might have been, let's say, a simple laparoscopic surgery was offered to the patient, rendered on the patient. But when the claim goes in, it's billed at a higher CPT level, a higher service level that says perhaps it was an open procedure with many complications. That's going to drive payment up, obviously. That would be much more costly in a fee-for-service world. In a value-based world, upcoding, again, takes the focus off the CPT and looks at the ICD-10 codes, the diagnosis codes, what's wrong with the patient. To inflate the severity of illness, you use diagnosis codes. And that could be saying that for every single patient who has diabetes, they now have a complication, right? That would drive up payment in a value-based world. Another way that fraud, waste, and abuse can occur in value-based care is coding conditions that didn't impact care, treatment, or management at the encounter. And what we're seeing in a lot of the litigation that's out there is that providers are trying to play catch up with value-based care, and they are moving perhaps too quickly, and they're dropping problem lists into their assessments without knowing the ICD-10 guidelines that tell us that in order to report a diagnosis code in the outpatient setting, it has to impact care, treatment, or management at that encounter. This is a big one for all of you auditors out there. We know there's heightened scrutiny and a lot of people have ramped up their internal audit efforts. It is crucial to delete erroneous diagnosis codes identified. That falls into the 60-day overpayment rule. It falls into Reverse False Claims Act when you identify conditions that are overinflated, that report a higher severity of illness, and thus drive a higher payment. Once you identify that in your internal audits, you do have to delete that code through your reconciliation process and make sure that you true up what the payment is. Submitting historical conditions as current. Hopefully for our patients, we're taking great care of them, and there's a lot of conditions that can be resolved. We want to make sure that when a condition is resolved, that you're using a history of code versus the active code for that. Again, it's going to be a driver of payment. A lot of providers haven't switched their mindset. So when they're looking at it from a clinical standpoint, they might not be doing it intentionally, right? Fraud requires intention, but it could lead to waste and abuse and inflated payments if you're not using the accurate codes to report historical conditions that might not impact care, treatment, or management at the encounter. Submitting rule out codes. Again, I'm going to advocate for our providers. They're trying to do the right thing, But the rules around reporting, documentation and coding sometimes clash with clinical perspectives. From a clinical perspective, a provider might be treating a patient and working up a diagnosis in their head. They don't have it definitive yet, right? They need to send out for further workup or further tests. In that case, they're trying to rule out a diagnosis code. It is not uncommon at all for a provider to choose the active code that they're trying to rule out and submit that on a claim. Now, if that's a chronic condition that triggers a payment, it's going to be an issue if that workup and the further testing comes back and the patient doesn't have it. Again, this is going to be a call to action for everybody on this call to make sure that you are doing everything you can for provider education and provider engagement. It all starts with our providers. They need to be aware of the many challenges and pitfalls where you can go wrong in value-based care. Submitting diagnoses from unapproved sources. This is where working with trusted vendor partners and making sure that your data submissions teams know the rules around what can be submitted for payment in the various models, in the various lines of business. They vary between Medicare Advantage, commercial, and Medicaid. And of course, Medicaid makes it even more complex because they're going to be different rules for each state. And then lastly, inflating severity of illness through improper use of combination codes. There are many codes, I'm going to use the Medicare Advantage risk adjustment model as an example, that drive payment, not for only one condition, but several conditions. I'll pick diabetes with chronic kidney disease. If a patient has diabetes and chronic kidney disease, that's going to drive a payment to cover the cost of diabetes, which is extremely costly, and chronic kidney disease, which progressively gets worse in patients. So you can anticipate higher resource needs for those patients. There's an ICD-10 code that will report both those conditions together, diabetic chronic kidney disease. If that code is reported and the documentation from your provider doesn't support both of those chronic conditions, you're going to see that if the external auditors come in and look, and it will result in a take back or a failure for that piece of the audit. So inflating severity of illness through improper use of combination codes happens all the time, sometimes with intention, which would be fraud, sometimes just through lack of knowledge that the provider might be looking at it clinically and saying, well, of course, if I'm treating the diabetes, I'm treating the chronic kidney disease. But that's where we have to become very familiar with the guidelines and the guidance that's out there. And it's very clear that both conditions, or in some cases, some of these codes are very robust, and 3 conditions are reported within a code descriptor. All of the conditions reported within that code descriptor have to be supported in that encounter. Oh, time for a polling question.
Okay, so we do have a question for the audience here that we wanted to ask. How confident is your organization in detecting and preventing fraud, waste, and abuse within your value-based care contracts? And I'm going to pull this poll up and you'll be able to interact with it. Here we go. And this is, by the way, this is anonymous and this is just for fun. So are you very confident, somewhat confident, not confident, or we are still evaluating our capabilities, or we haven't really thought much about it? So we're going to give it maybe, I don't know, 30 seconds or so for folks to answer here. And then we'll show the results and you can kind of see where you stack among your colleagues here. And again, this is anonymous, so feel free to answer honestly. Okay, nope. I'm seeing some results coming here. Jumping around.
Mm-hmm.
Close it down in about 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1, and I will go ahead and share the results. Okay, Amanda, Colleen, Ray, are you able to see the results on your screen? And if you wouldn't mind reading out for those calling in the percentages.
Colleen, you want to take that? Oh,
I
or
can't
do you
see
want me
it
to?
from here.
Oh, okay. So, not surprising. We have 7% saying they're very confident in detecting FWA when they're VBC contracts. 53% are somewhat confident. 13% not confident. 13% we're still evaluating our capabilities, and 13%, which is really interesting that the bottom three are all 13%, haven't thought about it, about potential FWA and VBC contracts. So there's usually a bell curve that we see when we start talking about preventing FWA and VBC contracts. So that is a little bit skewed to the somewhat confident and confident in the middle. But it's always interesting to see what people are thinking about in the VBC world. So,
and I will have to say, everybody on this call, you need to be striving for that very confident, because it's not a question of if anymore, it's when. And the auditors are coming out. I mean, specifically for RADV audits, every single year you are getting that audit. So we have to move the majority of people to that very confident level. And good job for those of you who have done that work so far. We can move to the next slide.
Yep. There you are.
So I've given you a tremendous amount of information. It's very new for a lot of our clinicians, a lot of our organizations. Big shift. How do you do it all? You're probably asking yourself, okay, where do we even begin? And I always love to lay a really strong foundation by creating a culture of compliance. These are a lot of rules to memorize. They're ever changing. So I'm going to give you this tried and true list of creating a culture of compliance. And what I recommend you all do is start building teams of independent thinking, critical thinkers. And what I mean by that is, don't have so many internal policies and procedures that you have to continually update and change as the regulations change. Instead, train your teams to be independent and know where they need to look for these updates as they happen. Of course, I'll start at the top. The Medicare Managed Care Manual, which OIG put out, I believe at the end of 2023. They only put out this type of guidance when there's a known area of risk. So it had been quite some years since they had put out this guidance. Read that. It will give you exactly where they're looking for, what they're looking at and where they're looking. Of course, you have your Medicaid and your CHIP managed care final rules that you want to be reviewing. Your ICD-10 CM guidelines. I've referred to them many, many times. These are guidelines that tell you how to use that diagnosis coding set that's so crucial for value-based care. While you might have coders on your team, they might have spent most of their careers on the fee-for-service side. It's a different methodology. You want experts in ICD-10 because that's how we're reporting for quality and reimbursement purposes. Your ICD-10 guidelines can be found at the beginning of your coding book. They can also be embedded in your encoders if you're using the electronic systems. Big change here to note, and not everybody's aware of it. ICD-10 guidelines are updated October 1st. During those updates, they'll add new codes, they'll delete codes. They'll also make changes to the guidelines. Those guidelines will highlight in bold what has changed from year over year. It's dry reading, right? Nobody enjoys reading ICD-10 guidelines. So the quick way to make sure that you're updating your systems and your teams is to take a look at the official ICD-10 guidelines when they come out October 1st. The bolded text is going to tell you what has changed. Another important update is October 1st has always been that one and done, here's the ICD-10 updates. Starting in, I believe it was 2022, they started adding routine updates in April. So you want to check those twice a year. I think most coders know October 1st is when ICD-10 guidelines come out, but not everybody knows that now there's a regular update in April, and it's important for your team's knowledge to check those updates. Next, we have Coding Clinic. Now, Coding Clinic comes out quarterly. To be truly transparent, this could be a very expensive add-on to your current encoder solution, and it might not be feasible for you to get it for everybody on your team, but you should have a designated person who is checking for these Coding Clinic updates on a quarterly basis and sharing that information out with the team. The reason it's so important is because ICD-10 guidelines, while they get better and better every year and more clear every year, there's often confusion or areas that are gray and people aren't quite sure how to interpret it. Well, that's where Coding Clinic comes in. It comes in for clarifications to those guidelines, and that's binding guidance. So as soon as it's published in Coding Clinic, as soon as that effective date that's stamped on the bottom of each Coding Clinic, it becomes effective going forward. So it's important that you hear that information as it's coming out, you disseminate it across your team, and you update any policies or procedures that you have. Of course, CPT is not going away. It still tells us how we're caring for our patients and the services that we're rendering. So you want to make sure that you're familiar with CPT guidelines. These are owned by the AMA. So depending on what code book that you use, they might be available right in the code book. If not, you want to have access to your CPT guidelines. And lastly, as we bring risk adjustment and value-based programs closer to the point of care, you've seen a huge surge in outpatient CDI, clinical documentation integrity, sometimes called clinical documentation improvement. These are new rules, relatively new space here for us. The leading guidance on how to query a provider, meaning if there's confusion in the record and we're not quite sure what happened and how this should be coded and reported, we're going to query the provider, which simply just means to question the provider for more clarity. AI and technology plays a huge piece in this new era. You want to make sure that anything that you're doing, whether it's through humans, AI, or technology, that you are referring to the ACDIS guidelines for achieving a compliant query practice. ACDIS stands for the Association of Clinical Documentation Integrity Specialists, and this guidance is guidance that has been mentioned in some of the current litigation that's going on. The way you ask these questions of a provider, it's very important that we don't lead the provider, or it looks like that we're asking questions simply to drive reimbursement and not to drive improved patient care. So I hope you find this list helpful. And now I'm going to turn it over to Amanda, who is going to share how to turn some of these existing silos into synergies.
Thank you. So I've talked a lot about integrating programs and around your revenue integrity, your FWA, and your value-based care programs. And really that integrated vision is kind of simplified into a couple or three things, really. You know, making sure every dollar is accurate, you're safeguarding, and is defensible. And we measure all that with KPIs, as we talked about earlier. And practically, that means share data across all of your workflows and your departments to ensure that there is synergies instead of silos. At the core of building this out, as you think about how to bring these together in your organization, it's possible whether you're a small organization or you're a larger organization. Some people just may wear multiple hats within that process, whereas it may be a specific role within an organization. But to start the process, you really want to establish an executive sponsor, have a steering committee, and set quarterly priorities around your teams instead of really just checking the box, working on your lists, creating backlog because there may not be the resources that you need. Finding those synergies, you can offset workloads and begin to manage processes more efficiently with joint resource planning, and then taking actions around, again, prepay, edits, education, and then the formal SIU process. Also creating a single source of data and a single source of truth for any records, whether that's an audit record, an SIU record, a claims audit record, and ensuring that there is synergy around the shared information to ensure that you've triaged things appropriately, and that one claim doesn't get reviewed by multiple different areas with multiple potential different outcomes as well, depending on where they fall within the life cycle. And then all of that really works better to get towards more of that prepay becoming the default, away from a post-pay pay and chase model as a safety net. That in turn reduces provider abrasion with coordinated outreach and then accurate results and workflows as well. So looking at these synergies, thinking about a high volume specialty where we see repeated modifier use, you've revenue integrity may create or correct the claim at the front end, and SIU may notice that the behavior is across multiple locations within that provider's group. And then the contracting group might see a fee schedule loophole that maybe the provider is looking into an opportunity. But when looking at that scenario separately, each solves only 1% of the problem. Fixing the corrected claim, but not fixing the location issue or maybe the fee schedule loophole. Separately, you only get a piece, but together you can solve all of the problem faster and more integrated to reduce abrasion with the provider and workload for your team. And that's not, the cost isn't just pay and chase. It's also, with that, it is the provider abrasion, but it's also member confusion. They start seeing edits made to claims, and they're getting letters. Their provider may say we're not getting paid for certain claims, and there's some back and forth, and sometimes the member can also get involved in that. And then in VBC, silos in the payment and the recoverability and the process can also impact utilization, submissions, and risk indicators. So the dollars and the performance incentives really kind of move in the opposite direction of where you're trying to go. So coming up with a model that's very integrated reduces your duplicative audits, your conflicting findings within your organization, time cycles and information and audits and processes are faster, and then you can move towards more of that prepay and away from that pay and chase. So thinking about it from a data and technology architecture, one source of truth, as I mentioned earlier, integrating, kind of how do you start this, right? How do you bring all of this together? So integrating your claims, your encounters, all of your data integration into one source of truth for an analytics model or a claims and full picture view of bringing all of your claims, your information, provider directories and contracts. Many of these items are very siloed within organizations. One that sticks out to me is always credentialing files. As leading an SIU, you may be going over and conducting an assessment or an audit or an investigation in the SIU, and if you're not pulling in the credentialing files and understanding the timelines of those credentialing files, I've had it where I was in the middle of an investigation and the provider was up for re-credentialing, and we could have used that opportunity to get additional information, renegotiate contract loopholes, fix some of the errors and issues and potential risk to us as an organization with that process. But credentialing went ahead and moved through, and next thing I know, the case became a bigger issue. And we ended up credentialing a provider into our network when we immediately had to summarily suspend and then remove the provider from the network and take legal action. So integrating all of your information, from your quality information to any grievance and appeals and those kind of things, is really important to have one source of truth. And then when you get all of that, it's really ingesting all of that, making sure you understand and normalize that data. We all know data can be the bane of our existence sometimes, but understanding what's in your data, what is feeding the data, also can help cleanse your data in the future, so that as that data is coming in, it can be easily and better integrated. So ingesting it, and then using that to detect it with rules and machine learning and analytics. And so identifying an opportunity to bring all that in and have an analytics platform or an analytics tool that you have, whether homegrown or from a vendor, is really important, because that is a way that then you can detect and then run that right into triaging cases for integrated case management platforms, and having the analytics integrated into your investigations, audits, or any sort of just reviews that you're doing from a revenue integrity perspective, integrating all of that into one platform where you have the history to bring forward. So then you can act on the whatever outlier or risk or concern that you have efficiently. And then depending on what you find, you have proper evidence and documentation. Corrective action plans can be monitored and managed, but not just from the SIU perspective or compliance perspective or revenue integrity department's perspective, or any of your other teams will know what actions are taking place and when someone's on a cap, or when recoveries are taking place. And then from that, you can learn and manage your feedback and outcomes, and come back and edit rules and models and structure and organization, and become more efficient. And so why does that matter, right? The revenue integrity and SIU sharing the same platform, you can get an efficient prepay and post-pay logic essentially in one pipeline. You have one single case record regarding those claims, and you've got all the evidence and the audit trails right there together. And then on the backside, dashboards, and able to manage savings and quality and timing for all of those, the work that you're doing. And then the audit trail, right? The audit trail of, do you have to take action, to just put a cap in place? Maybe a cap becomes a non-corrective action and they're not correcting their issues or the concerns that you have, and you may have to take something to law enforcement because it may be that there's intent. And if that's the case, then you have all that right there in one integrated program or an integrated case, where everyone from all the different areas of the organization that may or may not have influence to those set of claims have all their information documented in there. And so you have an audit trail that is defensible and complete, and you can quickly take action on that. So from that, let's talk about the detection to resolution side, life cycle. So you've got all of this information in, and you've got all of your information brought together. So then you're trying to detect issues, right? So from an analytics perspective, you have multiple lenses. You have codes, you have bundling and unbundling, you have contract compliance, statistical outliers, and maybe even time-based outliers, where a provider may be 45 minutes away from a member, but there's 10, 12 providers within a 5 to 10 minute location from the member's home. Now, some of those may be outliers because it's a university medical center with very specialized services. But if it's is more of a general service, maybe it's possible they could get it from home. They may be an outlier for other reasons, and bringing those providers there, or those members to them. So an integrated model will help you to detect through machine learning, rules, and network and signals there. When you move to the triage phase from that information, you can use the standardized decision tree. So is it an error? Is it abuse? Is it suspected fraud, or is it a medical necessity issue? And you have all of those integrated and built in where, an error, you can correct it, deny it, pay what's appropriate. For abuse, you can provide education, put a provider on a cap, or provide more enhanced modeling, maybe on a prepay basis. The suspected fraud, obviously you would want to open an SIU case and do a potential records request. But that error, if you have an integrated system, the error may feed that, oh, that error is an error, but now the next few times it comes in, okay, maybe this is a little bit more abusive, it's a little more flagged, maybe we should provide education to the provider and let's try to fix this issue. And then if that's not working, you have all that documented right within a system that when and if it becomes an SIU case, you have all of that history right there. And then from there, you can integrate your medical necessity reviews. So if you do any clinical or chart reviews, having an integrated system, you can have all that documentation right within the system. And then you can act with prepay, whether it's, updating your systems. You can update and clarify any system updates you may need to make from where you triaged and did an investigation, and track all of that within your actions. And then from that, when you go to close, you can identify root causes. Maybe that root cause from the actions that the provider took, you can take and then carry forward to other opportunities to prevent that in the future, and identify gaps and education needs and all those things that may help your provider network to avoid those issues in the future. So the analytics strategy, and I will go through this quickly so that I'm not repeating myself here, but there's several layers of really what you should be looking for in your analytics strategy. And that's, codes and rules, statistical outliers in their peer groups. Those are sudden trend deltas that move, seasonality that may shift, provider mix and such. Network, a layer, that third layer there of network and behavioral, that's, looking at it in these multiple layers of analytics in a cohort of providers with shared referrals and shared members, same day and same NPI patterns, unusual places of service, addresses of providers compared to members, and those kind of things around the network and the behavior of your member and your providers in there. The fourth layer of that is documentation and any signals and risk. And that is really a risk score. So having a risk score that comes out of your analytics that gives you a plausibility of potential fraud, waste, and abuse, and checking that against the data that you have, and against the quality submissions for your VBC as well. And then, all of these wrapped into then the governance. So if you have these multi-layered approaches to your analytics, you can then govern that information in the outputs and identify and monitor false positive rates, update models, and thresholds, and update potential flags for future action. So before we move on, we have a question around, a polling question around your data. So I'll turn that over.
Okay. And you will see that on your screen now. What are the biggest challenges your organization faces in managing data for fraud, waste, and abuse detection and compliance? Is it data accuracy and integrity, insufficient tools or technology for analysis, lack of resources or expertise, or is it regulatory and reporting complexities? And I believe you can choose more than one of these, so maybe your top two or so that would be your biggest challenges there. And again, if you're joining us late, these are anonymous. This is just kind of for fun, so feel free to answer honestly and accurately. And we're going to show the results here shortly so that you can see kind of where you stack among your colleagues. All right. Answers are still coming in, so we'll give it maybe about 10 more seconds and then we'll close it down. Again, what are the biggest challenges your organization faces in managing data for FWA detection and compliance? All right, I think most of the responses have come in, so I'm going to go ahead and shut it down in 5, 4, 3, 2, and 1. Okay, Amanda, are you able to see the results?
Yeah. So not surprising. They're actually kind of close with one larger outlier here. So data accuracy and integrity is 38%. So let me go to the top. Lack of resources and expertise was number 1 at 62%. Insufficient tools or technology for analysis is 46%. 38% was data accuracy and integrity, and then the bottom was 15% of regulatory reporting and complexity, regulatory reporting complexity. So not surprising there. Analytics is always difficult, and something we hear regularly from our clients. So thank you for sharing that. And we're moving quickly towards our bookend here. So I will click to the next slide and move through pretty quickly here. So this is just to share, really a model of how we work with our clients in bringing in analytics, an integrated analytics platform with a case management platform, and the analytics being integrated into the case management platform to then work through case collaboration with each of the areas that we've talked about with the VBC, your Rev Integrity, your compliance, and your SIU organizations all working together, and the synergies that are there to then really build a model of a cyclical process improvement and streamlining the life cycle, no matter how small or how big the organization is. So with that, we'll go through a couple examples pretty quickly here of just how prepay and SIU synergies work together and how bringing the models together can improve. So Colleen, I'll turn that back over to you.
Thanks. So again, I briefly mentioned this earlier. It's the misuse of combination codes. Putting those prepay edits will allow somebody who is certified in coding to make sure that all sections and portions of that code are supported. Set up your audits around these large combination codes. And then again, coordinated provider education and monitoring. And as Amanda was speaking, I was just like, yes, we need to do a better job with the coordinated provider education, because that provider abrasion is real. And the mistake I see time and time again is you have very well-intentioned teams within one organization going out and giving their own message to providers. You want to make sure that that messaging is aligned, right? So you can't have one group, maybe your quality team, going out and saying one thing, and then your risk adjustment group going out and saying something that's just slightly different, because that's going to create confusion and it's going to create provider abrasion. Beyond that, I just want to take another step into what Amanda was saying, and that is make sure your system configuration is set up correctly, because there's nothing worse for provider abrasion than for us to be telling the provider, do it this way, this is the correct way to do it, and then they submit a claim and it gets kicked out. All parties here have to be speaking to each other, and the last thing we want to do is go out there and give guidance, and then it comes back where internally your organization's not aligned, whether that be through various departments' education or through your data analytics configuration areas.
Great. So here's another example, and this is, around VBC. And so the scenario, is if you have a risk score that abruptly jumps with documentation, there's usually in that jump, you'll have some inconsistencies in the documentation because providers are quickly trying to potentially adjust those risk scores for VBC, but may not have the documentation, as Colleen mentioned earlier, to support that. The opportunity here is to really bring in all of your groups to work around the coding issues, potential issues, the integration, like Colleen said, where you're making sure that the provider education is there, but also that you're looking at the potential submissions of those claims cohesively as a group, and bringing in everyone, each of those departments to take a look at that. And the recommendation we have on those is looking at chart validation, obviously, potentially putting the provider on a cap, but really important in some of these VBC examples, but also with your SIU, is to make sure that when you think about the provider education or the impact of some of these claims that are submitted, is to think about the vendor. Sometimes the vendor is what's causing the potential problem, whether a vendor that you're using, and making sure that they're aligned with your payment policies, but also that the provider education is also going out to any potential vendors that may be involved with this or with your organization. And then, the outcome of doing that is you should see the risk score go down of potential FWA, improved quality of the data coming in or the claims being submitted, avoiding some of the codes being added, as Colleen mentioned, unnecessarily with a diagnosis to a member, and potentially fewer escalations internally of confusion of the provider, appeals, and all of the things that come along with that. Anything to add to that, Colleen?
Yeah, I would definitely say to look at disease prevalence. It's a great place to start. If you're looking at providers all within one region and you have an outlier where, my goodness, why does this provider report COPD 45% more than the rest of the providers in the area? Well, could be legitimate. It could be that they're the premier pulmonologist in the area and all complex COPD patients go to them, right? That would be a valid reason. But in a lot of cases, when you see these disease prevalence outliers, it's a good place to start your SIU and your payment integrity efforts.
So we'll move through these kind of quickly. So make sure, as we talked about earlier, when you bring all of these together, it's also important to make sure that you're bringing your providers along in the process. And so, and having a strategy on how to manage each of the roles within the process. And so, we recommend a provider engagement playbook, and that's around a tiered approach. Like, how are you going to approach the SIU process, the rev integrity process, the risk adjustment process, and the VBC process all together in this? And that's really a tiered approach with education, corrective actions, and then enhanced sanctions. So putting together your playbook of how you're going to manage and monitor and work together in this is very important, with clear actions around who's doing what, having a RACI about who's consulted, who's involved, who's taking action. All of those things is very important to know who's on first with those. A single coordinated message to providers, avoiding the duplicative outreach and the provider abrasion, maybe providing tips, kits, audit guides, tip sheets, all those things to your providers so they can do some self-audit to prevent. Essentially, you are trying to, as we all are, trying to prevent errors, overpayments, and provider abrasion all together for a cohesive approach. And then you're able to measure, how do you want to measure the program, and how are you planning to measure your program? And that may be dispute rates, overturn rates, reoccurrence. It could be appeals. It could be looking at your risk scores and monitoring the delta in your risk scores as well. And with that, how do you report this? So you've brought all these departments together. You've pulled together a group with a champion to kind of manage this process with bringing all of these groups together. You've got the synergies, you're bringing together analytics and case management and integrated processes with regular meetings and outcomes and cycled back into the process for process improvement, but you need to be able to monitor and manage it. And so that's where the KPIs and the dashboards come in. So the KPIs that matter, this is what I use in dashboards for really those high levels as you're beginning to build those out. And I won't go through each of those. They're pretty self-explanatory, but these are the kind of things that are the kind of KPIs you want to monitor and manage as a group for each of the functions that you've integrated, to be able to push those out through the organization and to take those into audit committees and report the success of really integrating your revenue integrity, SIU, and VBC programs and the outcomes and really show the hard work you're doing. And from those KPIs, then you can create dashboards, right? Those pretty things. And really these are, where do you want to, what types of dashboards do you want to report out for the different, and I don't know how I pumped that, the different organizations or the different audiences that you have. So you have an executive dashboard. That's more of your total savings of your SIU efforts, combined with your rev integrity, combined with your VBC identified dollars. And so looking at your savings, your ROI trends, high risks, and kind of what that high level executive look at those provider distributions and current investigations and such that they would be interested in. Then having an operational dashboard, that's really your day-to-day work. So what are your aging reports? What are your service level agreements that you've set for yourself within each of these organizations, with each of these functions, whether that's rev integrity, VBC, audits, and SIU, productivity of your reviews, turnaround times. All those things are really important to monitor and manage and ensure you are not delaying cases, because the worst thing to do is you do end up having to take something to law enforcement, or it becomes a case that goes to a regulator and their response, from a Medicaid Department of Insurance, Medicaid office is saying, why did it take you 45 days to request the chart, or why did it take? So this is a way to really monitor and manage productivity. And then from the provider view is, findings and caps and really that monitoring and managing at a provider level that you can share with your network teams and groups as such. And bringing all of that together to really show the impact of integrating these programs and the success that comes from it. So with that, I will open it up for questions.
All right. And we do have some questions that came in. And by the way, if you have a question for any of our speakers, or just in general, go ahead and drop that in now. And in no particular order, let's go ahead and get started. We only have time for a couple, so we'll rush through it here. But first is, what does ACT stand for? It's a simple one.
I don't remember where that was at on there was a reference, maybe.
Yeah, maybe we'll need to get back to you on that one.
We'll get back with you, because I got to remember what context it was on a slide. Sorry about that.
Yeah, no worries. Okay, next question here is, let's see, can you expand on the 6-day overpayment rule?
The 60-day overpayment rule means that once you find that you've been paid by a government program, Medicaid or Medicare, that you have an obligation to return that payment within 60 days.
Great. And then this might be the last one, unfortunately, we have time for here is, what is an example of what fraud looks like in a contract versus actual practices?
I'm assuming they're talking about a VBC environment. Colleen, do you want to give a fraud example for VBC contract? I'm assuming that's the type of contract they're talking about.
Yeah, VBC,
so maybe COPD or something.
Yeah, you want to be really careful whether you're on the payer or the provider side. Payer side, be very careful about how you incentivize your providers for success in value-based care, because some of those, when looked at from the outside, from the regulators, are going to appear that you might be acting with intention to just drive up risk adjustment scores or quality scores versus better patient outcomes. And that could be as simple as one example I can give you is incentivizing providers for a specific recapture rate, saying you're going to get an additional bonus payment if you recapture 90% of your chronic conditions year over year. While it appears that it might be reasonable, it's not, because you can't guarantee that code was correct to begin with, or that the patient still has it. So incentivizing on recapture rates, I would tell you avoid that, because it might be looked at as intentionally doing something to drive up risk scores rather than to focus on patient care.
Gotcha. Unfortunately, we are out of time. Thank you, Colleen. And Amanda, Ray, thank you all for a fantastic, very rich presentation here. As we close out, I wanted to encourage you all to head over to vbcexhibithall.com and check out the CoventBridge virtual exhibit booth there. There's a lot of great resources. You can read up on them and what they're doing, and of course, reach out to them through there. And there's also, that's in the library there is where this webinar is going to be archived, along with other webinars we've done with CoventBridge, and on a variety of other topics. So go ahead and check that library out there. And then finally, if you'd like to reach out to any of the speakers today, their information is here on the screen. This will be in the slides that we make available for download, which we're going to send a link to here shortly. So thank you all so much for coming. Thank you again, Amanda, Colleen, Ray, for a wonderful presentation. We hope that you join us on the next one. But until then, have a great rest of your day. Bye-bye.
Thank you. Bye.